Okay, welcome everyone. My name's Laura Erskine. I'm the director of the Center for Healthcare Management and the host of this case competition. Um, I'd like to welcome all of you. I want to point out a couple of folks. I can't see out there, but somewhere Dean Brookmeyer is in our audience. There he is. Dr. Brookmeyer is the dean of the Fielding School of Public Health. We also have Dan Gentry, who you met last night. Dan is the president and CEO of AUPHA. Any other VIPs out here? Everybody, right? Okay. Um, I also want to really recognize and thank our sponsor. We have worked each year with UCLA Health. This is our 7th year on this case competition. They are amazing partners. You met some of their execs this morning when you were presenting. You have another group that you'll meet this afternoon as these presentations go on. 92 teams from across the country submitted cases this year. Those 92 teams came from 36 universities, and 8 of those 92 teams started this morning. The top 8, and now the top 4 are going to present this afternoon. All 4 teams that are presenting this afternoon will get cash prizes. The first place prize is $12,000, second is 8, third is 4, and fourth is 2. It's important to be respectful of each of the teams, and we want to keep their school identities blinded through the rest of the afternoon. So please don't show any undue favoritism or hooting or yelling your mascot or, any of those kinds of things. Also, we ask that once a group has started presenting, you don't enter or leave the room, just to be respectful of their time. Each team will have 15 minutes. They'll get some warnings, 5, 2, and 1 minute remaining. And then the judges will have 10 minutes to ask the team questions. Those of you who did not spend a glorious long weekend in November analyzing this case may want a little background. So they received some information about UCLA Health, about the LA healthcare market, about CI care, strategic initiatives, that kind of thing. And then they read this. As healthcare continues to become increasingly complex, artificial intelligence is emerging as a transformative tool. AI promises to impact operations by improving efficiency, reducing medical errors, and enhancing the patient and clinician experience. Yet, it also introduces new risks, ethical questions, and implementation challenges. UCLA Health is a health system that has grown significantly over the past several years, including in ambulatory specialty service lines, and it has helped to provide comprehensive care closer to home. The hospital system has also continued to operate at capacity, often exceeding 100% occupancy due to the needs of our community. Operational excellence, world-class patient experience, and being an employer of choice continue to be high priorities for the organization. AI has the potential to reshape healthcare, but large systems like UCLA Health must proceed thoughtfully to ensure it improves care, protects patients, and supports staff. So the teams were asked to develop a 5-year AI strategy for the health system. Their strategy was required to include key goals and a prioritization of those goals, areas where AI could provide the most value, and an implementation plan that came with some cost estimates. So with no further ado, we're going to have our first presenters, servant leaders in innovation. We'll have the judges introduce themselves, and then the team can go ahead. And I just, as a final reminder, ask that you silence your phones. Judges, do you want to introduce yourselves? Do you have a mic?
Hello. Hello. Hi, everyone. Jeff Butler. So I'm COO for our Community Clinic Network. Excited to be here.
Hi, Paul Lukac. I'm the Chief AI Officer at UCLA Health, and I'm a pediatrician by training.
Good afternoon, everybody. My name is Julia Gaviria. I'm our Chief Patient Experience Officer.
Good afternoon, everyone. I am Deisha Brown, and I am the Senior Director of Community Clinics Operations.
Thank you. Everyone, my name is Colin McAnally, and I'm here with my colleagues, Jack D., Chloe Ham, and Olivia Brockman. We want to thank you all for the opportunity to speak today, and we are servant leaders in innovation. Today, we're presenting a forward-looking strategy for how UCLA Health can best utilize artificial intelligence and where it's needed most. And where it's needed most is patient access. Our goal today is to show how AI tools can be implemented responsibly and with intention to improve things like throughput, quality and safety, and long-term sustainability for UCLA Health and its mission. UCLA Health already has the right mission and vision of healing humankind one patient at a time. We want to make it perfectly clear that this strategy is not designed to automate the human aspect of care, but rather through this strategy, it's going to empower UCLA Health's physicians and workforce to be more empowered to live the CI care approach when delivering care.
Patient complexity is increasing, and UCLA Health's hospitals are operating at or above capacity. There's an opportunity within AI and the AI Council at UCLA Health to improve patient access. It just needs the right strategy. Looking at our cross-industry research, we found that AI is successful in improving throughput. For example, BMW implemented AI computer vision systems into their assembly line, and through this, they saw a 30% decrease in their vehicle inspection times. And as a result, they had a accelerated throughput and improved quality control and operational efficiency. You see, AI works best when it supports people and decision-making, not when it removes human judgment. Now, despite AI's successes, implementing AI in an organization often fails from our research for the same reasons. They remove humans from the loop, and they don't have a clear direction on how to properly implement these tools. Organizations often launch pilots that don't scale, or they have these AI tools implemented into workflows that aren't ready for it yet. With this, it's clear that AI can provide meaningful value, but it just needs the right strategy to guide it. And this is the missing link.
So now to turn back to UCLA Health, it's clear the organization isn't lacking vision or ambition, but the challenge is incorporating these long-term goals into an AI strategy. That requires rethinking how workflows are coordinated, supported, and designed across the entire system. So how do we implement these goals into an AI strategy? The first step is evaluating the current state. And when evaluating UCLA Health's current state, it's clear there are a few areas of concern. These include throughput pressure, fragmented data, and call center strain. And individually, these can look like separate operational challenges. But when we step back, it's what they're pointing to together, which is UCLA Health is currently managing more demand and more complexity than the current access structure was originally designed to sustain. So these insights is what led us here. From an enterprise perspective, access is a constraint that governs everything else. And like Olivia mentioned earlier, UCLA Health is consistently at or above capacity, meaning as we accelerate into the future, access is the goal that lags the farthest behind. That's why we focus on access as our value driver. AI-enabled access management is the accelerator that will take UCLA Health from managing complexity to commanding it.
So earlier, you heard Olivia mention the missing link. So what is the missing link at UCLA Health? The missing link is coordinated access management. So think of it this way. Common access-related gap is cancellations and no-shows. So say you have a clinic that has a higher than normal rate for cancellations and no-shows. And meanwhile, in the same health system, you have a clinic that has patients waiting weeks for an appointment. Through coordination, you can develop solutions to meet the needs of these patients in a quickly, effective, and efficient manner. So this coordination becomes the strategy, and it also becomes an avenue for AI to plug in to facilitate that coordination and also to develop those solutions to meet the needs of the patients. So we are calling this strategy Centralized Access Management Intelligence, or CAMI. So the key takeaway here is that the future value for AI at UCLA Health can be accelerated, but only if CAMI is built and prioritized now. So to put this in perspective, I'm going to walk you through how it answers the questions who, what, where, when, why, and how. So what is CAMI? It's the overall strategy to coordinate access management powered by AI capabilities. And who owns CAMI? UCLA Health AI Council. They'll be the ones to set priorities and make sure that tools and capabilities as plugged in align with their already value framework and risk assessment strategies. And where this will be embedded is across the system. UCLA Health AI Council will be the one stewarding this across the organization. And when this needs to be implemented is right now, because as Olivia mentioned in her cross-industry lessons, the missing link is a clear strategy, clear problem statement, and the proper governance and human-in-the-loop framework that allows AI to scale successfully. So that's why this is important, and how to operationalize this strategy we'll walk through in our implementation plan. But first, Chloe's going to discuss some access-related AI tools that exist today and the value that they can provide once plugged into a system that has CAMI as the strategy.
Now turning to some value pathways. Like Jack mentioned, this is really just looking at current AI tools that exist today and how they can be used to help better coordinate access. This set focuses on predictive insights, workflow support, and intelligent coordination, representing how AI can be applied to demand, operations, and patient coordination when guided by a centralized access strategy. Now looking at some more value pathways, utilization optimization, community partnership integration, real-time dashboards, and system-wide command center views represent additional areas where AI can add high value when embedded within the CAMI strategy. These areas highlight how access decisions can be more informed, monitored, and adjusted in real time.
The implementation plan is the operational roadmap for this strategy, CAMI, as Jack described. The key decision in all of this is sequencing. We do not want to begin just by buying a bunch of AI tools, but we want to create the proper readiness, governance, and workflow standards across all of UCLA Health. This is what operationalizes CAMI. We created a phased 5-year approach for how UCLA Health can better coordinate access management powered by AI.
So the first phase of the implementation plan is the discovery phase, and this is where the foundation is built. So here you'll establish governance with the UCLA Health AI Council. They'll be the ones, as I mentioned, to steward this across the organization, build buy-in from executives, patients, clinicians across the organization, and set project work teams to deliver the strategy. Here you also establish data readiness scores across the system, map current state workflows of what access currently looks like today to identify those friction points, and then also develop baseline KPIs, which will then be used as a benchmark as you move forward and start to implement AI tools. So once this foundation is built, then we move into phase 2, which is the design phase. And so here you're building the bridge on top of that foundation to connect you to the right AI tools and capabilities. So what this looks like is working with clinicians, patients, end users to design what access should look like and what workflows should be at UCLA Health. So by doing this, it really flips the script, because oftentimes organizations are approached by a shiny new tool or vendor that's telling you all the great benefits that it can provide. And while that may be great and you try and plug it in and jam it into your system, by operationalizing a coordinated access management strategy in this way, you are going to connect to the right tools and capabilities that will allow you to scale and deliver the greatest amount of success.
Once UCLA Health has built that bridge from the foundation, you can then move into phase 3A, acquire or build. Now, phase 3 was intentionally divided into 2 separate parts to separate solution selection from real-world testing. Phase 3A is where UCLA Health will identify or develop AI capabilities that align with CAMI and improving patient access. With input from clinicians, physicians, the AI Council, and frontline workers, they can clearly identify which AI tools and vendors will best suit this mission across the enterprise. Now, 3B builds on 3A by moving from selection to controlled piloting of these AI capabilities. UCLA Santa Monica Medical Center was chosen for piloting because it mirrors UCLA Health's core access and operational workflows, but at a slightly smaller scale. While patient demographics may differ from site to site, Santa Monica's lower capacity and broad service mix make it the ideal place to conduct these controlled pilots.
So now looking at phase 4, this really builds on the pilot by moving from controlled testing to system-wide implementation. So at this phase, tools are deployed at full scale across all UCLA Health hospitals and clinics to standardize how access is managed day to day. Meaning the focus is really shifting from proving that feasibility to embedding the tools into routine operations, ensuring the tools can operate at full scale effectively. Now, this next phase is really about ensuring the tools can hold up over time and can be adjusted as needed. Obviously, throughout the rollout process, monitoring and adjustments are happening, but here it becomes more routine and intentional, meaning UCLA Health is regularly looking at how access is performing, and most importantly, making refinements as patterns change. Now, finally, this final stage is really about long-term sustainability. With the CAMI strategy in place, UCLA Health isn't changing how access works every time a new tool or capability comes along. Instead, new AIs or other innovations can be added, adjusted, or retired without creating that fragmentation. So success at this point is really about that CAMI strategy holding up over time and giving UCLA Health a solid foundation to leverage AI responsibly, support future growth, and keep access aligned with the mission, all while keeping humans in the loop.
It's important that there's intention in structuring the strategy to mitigate any AI risks. There's a need to explicitly call out bias, alert fatigue, over-reliance on these tools, and any data inaccuracies that are produced by these tools. And how these risks are mitigated is by human-in-the-loop design, rigorous testing and validation of these tools, and constant monitoring of these tools. We also need to focus on investing in education for staff and patients as to what these tools are, why they can be trusted, and how they're used appropriately. Again, these tools are not designed to automate care, but empower UCLA Health care workers to better live the CI care approach.
So now turning briefly to the finances. The numbers you see here today are intentionally conservative. They are based on operational improvements rather than aggressive growth or new revenue assumptions, meaning the value primarily comes from improving how the patient is moving through the system as a whole, better use of existing capacity, smoother throughput, better operations in the call center, and most importantly, fewer missed appointments. This also doesn't assume new facilities or meaningful workforce expansion. Instead, the investment primarily comes into integration, governance, and workflow alignment. This allows value to accrue steadily as the strategy is implemented and scaled. So over a 5-year horizon, this translates into a positive net benefit, a modest but credible ROI, and a break-even point just under 2 years, demonstrating how operational value compounds once access is coordinated at the system level.
So to ground these financial assumptions, we took a look at a documented peer example from Jackson Health System. They implemented as part of a system-wide initiative, a partnership with Qventus, which is an AI vendor, to employ their suite of tools to improve access-related measures like length of stay, ED boarding times, and unlock excess capacity. So we use this as a baseline as the benefit that you can capture when implementing one tool or one vendor in a system that's aligned with CAMI. But CAMI goes a step further by really giving you the runway to deliver significant value because you'll be able to scale AI tools and vendors appropriately to deliver the most value.
And this is about more than just the money. AI access and AI tools become a system-wide capability for UCLA Health. It's going to improve the patient experience by making it more safer and efficient. It's going to improve the workload for physicians by reducing uncertainty and friction. And most importantly, it's going to make UCLA Health more sustainable into the future. Artificial intelligence is here, and it's going to be the organizations that have the proper foundation and know where AI tools are actually needed that are going to excel into the future. Through CAMI, UCLA Health will know that patient access is this need for UCLA Health. And UCLA Health is going to be able to be innovative with purpose while supporting its mission. And UCLA Health's not just going to be able to survive in this new future of artificial intelligence, but it's going to be able to thrive. Thank you, and we're happy to take questions.
This is on. Can you guys hear me?
Yes.
Yes, okay. First of all, great job. A lot to think through. Very, very thoughtful. So thank you guys very much. That was wonderful. Question for you that we're kind of debating internally here. A lot of the tools I think that you guys probably think through will be patient facing, meaning they're going to help with patient scheduling appointments or throughput, things like that. Have you thought about in your strategy, how would you communicate some of these changes about AI? Because we're a very service related team right now, a lot of touches with actually staff. And so this would be a little bit different. So any thoughts about how you guys have thought about how to communicate some of that to the patients?
I guess I could go first. Artificial intelligence is really unique because it's excelling at such a fast pace. And I feel like it's also kind of a buzzword now. So I think we use the word intention. It's going to be really important to make sure that we're upfront with patients on what these tools are. I think it goes back to that talking about education, investing in education, not just for staff, but patients, and finding a way for the opportunities for the providers, the people that are seeing the patients first, to educate them on these tools that they're using patient facing. I think that will go a long way if the providers, it's all about getting that buy-in from providers about what these tools are that you're implementing across the system.
Thanks, guys. That was great. I have a follow-up question. So you're probably familiar with the concept of people process technology. And you correctly pointed out in your phase 1 and phase 2 how important it is to assess current workflows and then to modify workflows. But that is much easier said than done. So how do you achieve this workflow change at scale, knowing that that's not something AI can do, but that is more of a management challenge?
I think that kind of goes back to leading with building this foundation first. I think if you start with the tools or you start with the vendors that come through the door with a shiny new tool and benefit capability that you want to implement, I think that would push back on that and not make it as seamless of trying to build that buy-in from the people that you're, going to be helping and enhance their workflow. So starting by working with them and keeping that human in the loop and keeping them in the process from start to finish is really the key. And it's hard because everybody wants like a quick win, get a AI tool right now and plug it in, but really taking the step back to build the internal framework and foundation is really what will accelerate the value in the future.
And to add to that, obviously, when you are making workflow adjustments, it's going to be a culture change. So that really requires having not only that buy-in, but having people feel like their voices is heard and they have a voice in the actual strategy as well.
Oh, great. Okay. Again, great job, everybody. What would be your biggest concern with this strategy?
I'd be happy to take that. We talked a lot about, and I'm kind of going back to how I answered the first question, is artificial intelligence is moving at such a rapid pace. And I think society as a whole doesn't really know how to quite grasp this. I think one of the biggest issues with implementing this is being able to mitigate all the risks through the AI Council or the AI Governance Board at UCLA. I think that's going to be pivotal. I think it goes back to vigorous testing of these tools and knowing how to properly test these tools before we roll them out at scale. Because that's the whole goal of CAMI, is being able to roll out tools at scale across from one clinic or to the Ronald Reagan Hospital all over. So that's what comes to mind.
And to add to that, as you're starting, it's obviously going to be like we were talking about the workflow change and the culture change. So it is going to be a heavy pull at the start. But as that CAMI strategy is starting to be implemented full scale, it becomes less of a heavy pull.
I echo the sentiment that you guys did a wonderful job with this presentation. In your review of Jackson Health as a peer organization, were there any lessons learned that stood out for you?
Yeah, I can take that. So Jackson Health is of similar size and scale, and they serve a similar population in Miami, Florida. What we saw there that they really made this partnership with Qventus to kind of build that strategy and build that coordination. Like they approached them first to kind of be the ones, they were the outside consulting vendor to come in and take total control and deploy their AI tools. This would be going a step further by UCLA being the ones to build it, because UCLA Health knows UCLA Health the best. So by walking through these steps and really building it with intention, then you're able to really see system-wide success from AI at scale versus just relying on a AI tool or vendor company to come in and do it for you.
Thank you.
Oh, okay, that was not, I have one. That was, oh, okay. Thank you. Oh, where's the pen? It's here. Thank you.
Our next team is MEM Consulting. Judges, you'll find the presentation for this team after tab 2. Start by having the judges introduce themselves, then the team can go. Yeah.
All right. Good afternoon, everyone. My name is Deisha Brown, and I am the Senior Director of Community Clinics Operations.
Hello, I'm Julia Gaviria. I'm our Chief Patient Experience Officer. Oh, hi.
Hi, I'm Albert Dentugan. I'm the Chief Data Analytics Officer.
Hello. Hi, Jeff Butler, COO for our Community Clinic Network.
Paul Lukac, I'm a pediatrician and I'm the Chief AI Officer at UCLA Health.
Good afternoon, everyone. Thank you for joining us here today to present our solution, Transforming Healthcare Navigation, Agentic AI at UCLA Health. My name is Morgan, and I'm joined by Elizabeth and Misha, and together we are MEM Consulting. Here's just a brief overview of our presentation today. To set the stage, UCLA Health is currently facing high ED utilization, high call abandonment rates, and capacity strain, all of which threaten patient access, care continuity, and threaten the long-term success of UCLA Health. To uphold its CI care values, UCLA must adopt a strategic 5-year agentic AI strategy focused at improving patient access, reducing frontline burden, and sustaining the reputation of being number one for those who come first. Our strategy builds upon UCLA's strong foundation, ensuring an equitable, scalable, and sustainable AI adoption strategy. Here's just a brief overview of Los Angeles and its population area, as well as its payer mix. And as you can see in the bottom right-hand corner, there is high ED utilization in the area, which we noted as an opportunity for care redesign. So our research first began conducting a gap analysis comparing the current state of UCLA Health to our ideal future state. So currently, patients at UCLA Health are facing many barriers to care despite existing initiatives, but we envision a future where they are able to be personally navigated to the appropriate care sites. And we'd like to enable this with agentic AI integration across all UCLA Health platforms in order to act as a digital front door to UCLA Health care sites. To illustrate the current patient experience, we'd like to introduce you to Maria. Maria is an elderly woman with multiple chronic health conditions. Her primary language is Spanish, and she's not very comfortable with digital health tools. Maria is currently experiencing symptoms of dizziness and chest discomfort, so she's considering going to the emergency department. If she goes to the ED, she will receive clinically safe care, but this will be operationally unnecessary. With long wait times and language barriers, this is an overall uncomfortable experience for Maria. She also leaves the ED exhausted due to high out-of-pocket costs and transportation challenges. Currently, the state of AI in healthcare has many generative tools. These are able to provide information, but they cannot actually coordinate care. For patients like Maria with limited tech and health literacy, this still poses a barrier. Agentic AI is able to go a step further with the ability to take action within pre-approved clinical guardrails. This is able to execute the next best step for patients and reduce administrative burden on clinicians. This allows them to act at the top of their license and guides patients to the right care at the right time and place. In thinking about how our AI could work in healthcare, we first looked at several other industries, and we'd like to highlight Amtrak's use of their interactive voice assistant, Julie. Julie is able to understand natural conversational requests for things such as scheduling and reservations, and with millions of calls annually, this significantly reduced the burden on human call agents. Across all industries, our key takeaway was that our agentic AI model could have the capabilities to interpret natural human inputs, streamline workflows, and perform autonomous actions within bounded limits.
All right, so as you could probably tell from agentic AI in those industry use cases, the common thread here is access across the entire navigation system, right? And so we're thinking about our healthcare model from the same lens. How do we streamline our operational workflow in a manner that increases navigation to the appropriate sites of care at the right times? So when we think about Navi, we're not just adding another app or another chatbot. Navi is agentically able to orchestrate care by understanding why a patient is reaching out and understanding the patient's intentions and then executing actions safely. Okay, so back to Navi. Let's take a look at how Navi interacts with our patients. So bring it back to Maria. She's experiencing some symptoms that cause her some anxiety. So she decides to call UCLA Health. This is where Navi comes into play. So Navi is able to reference all of Maria's EHR health data and then asks Maria a protocol-based set of questions while screening for red flags within predefined clinical guardrails. In Maria's case, no emergent symptoms are detected. So Navi routes Maria to same-day emergent care, schedules the visit for her, arranges for her to get free healthcare transportation, which we'll talk more about in our Uber Health partnership. And it does all of this while explaining this to her in her native language. So to frame Navi responsibly, we're going to think about operating this from our BITS framework: build, integrate, transform, and scale. And this ensures that we're not just launching technology, but we're sequencing it responsibly and strategically. So into the build phase, this is where we think about the infrastructure of Navi. So we know that Navi is multimodal, multilingual, and patient-centered. But we've talked about Navi from sort of the patient-facing side of things. But aside from the patient-facing direct side, Navi is also able to streamline workflows and to improve provider and patient experience from the back end. An example of that would be its ability to help close care gaps by leveraging ADT feeds to enable post-discharge follow-ups, which can help reduce readmissions, as well as to proactively mitigate any sort of risks or complications with the patient. So when thinking about Navi's impact, there's the patient impact, which we discussed with Maria, but there's also the enterprise impact at UCLA Health. And this impact falls across 6 key domains, all of which are synergistically related with each other. So let's take readmissions again as an example. When we reduce avoidable hospital readmissions, we're improving quality and outcomes, but we're also increasing operational efficiency. We're also increasing throughput optimization. We're also increasing the patient experience, and we're also reducing avoidable costs, contributing to financial stewardship. In terms of our investment costs, we foresee a $16.3 million investment in the building and integrating of Navi, as well as a reoccurring $4 million over the course of our 5-year build and deployment, coming to a total of $36 million.
So now we're on to our second phase, integrate. This phase focuses on embedding Navi seamlessly within Navi's existing ecosystem, ensuring alignment with patient workflows, operation systems, and patient data engagement tools. So as you can see here, Navi is depicted as a central connector, unifying clinical, operational, and patient data into a scalable real-time model. It integrates seamlessly with the EHR, supporting scheduling, triaging, and cost of care analytics, as well as incorporating social determinant and community health data. Through links with wearables and health apps, such as you may know, maybe an Oura Ring or a Apple Watch, Navi will be able to fuel equity dashboards, risk predictions, and just create a more data-driven patient experience for the patients. So as we know, data security and privacy remain the focus to any AI initiative. Navi will adhere strictly to any federal regulations, including HIPAA, to safeguard patient data. So leveraging the UCLA's AI Council, we will proactively embed risk management and bias mitigation frameworks throughout the system, ensuring a trustworthy, transparent, and equitable experience for every patient. So to complement Navi, we recommend expanding the current Uber Health partnership that we've seen with the Medicare Advantage program. Our proposal offers 1 free ride annually to a patient going to a UCLA Health site. Navi will be able to identically schedule these rides for the patients, which addresses the transportation barriers that are seen disproportionately throughout Los Angeles with the traffic and everything that's going on there. We have a projected cost of $4.9 million with a beginning utilization of 10%. So now that we have Uber Health and Navi in place, let's bring it back to Maria. With both of them in place, Maria's experience has been transformed. She now has a free guaranteed ride to a UCLA Health site. Her barriers to access are removed. She arrives to the right side of care on time, and she grows in confidence and health literacy when interacting with the UCLA Health System.
The next phase of our strategy is transform, where we'll be establishing our Navi pilot as well as implementing the change management plan. So our change management plan starts with leadership and governance. As Morgan mentioned, we'll be utilizing UCLA's Health AI Council as the governance body. For stakeholder engagement, we'll be engaging with stakeholders such as executives, clinicians, and patients very early on, maintaining that open communication to foster buy-in. Our pilot will be launched in year 3 to train staff as well as build provider confidence with Navi. And to drive continuous improvement, we will use staff and patient feedback throughout the pilot process, as well as evaluating performance against defined KPIs. Our leadership and governance will be led by the UCLA Health AI Council. They will be overseeing the internal and external IT teams, and they'll also be maintaining communication with clinicians and patients to support continuous feedback and learning. For continuous improvement, we'll be leveraging the PDSA cycle to make any refinements before we prepare for full implementation of Navi across the UCLA Health System. And for our pilot, we intend to implement this at the UCLA Santa Monica Medical Center. We first chose this because of its diverse population, which is roughly similar to the diversity of the UCLA Health System population as a whole. We also saw that this medical center had the highest ED utilization in the entire system, so we felt this had the highest potential for impact. Overall, we felt this was an ideal pilot environment to make refinements and preparation for rolling out Navi to the entire system. For performance monitoring, these are some KPIs that we will be evaluating throughout the pilot process. Targets such as our 10% reduction in ED visits and reducing call rates. These are based on outcomes seen in similar pilot studies. And we're also evaluating targets such as patient provider satisfaction and navigation accuracy to ensure that Navi is being safe and successful system-wide.
All right, we've now reached the final part of our framework, scale, which is where we focus on enterprise-wide adoption while focusing on value and quality. So we just talked about our pilot program in Santa Monica, but we're focusing on how we can leverage those continuous improvement principles and KPI monitoring to drive scalability to the entire health system. In terms of our timeline, we have a 5-year implementation plan. So in the first year, we're focusing on the infrastructure build out of Navi. In the second year, we're focusing on our partnerships with Uber and Epic. And then we're also focusing on staff education to really understand how Navi's impact can affect existing workflows and how we can better anticipate those changes. The third year is the pilot program at Santa Monica, and the last 2 years are deploying it system-wide to UCLA Health. In terms of finances, here's our 5-year pro forma. So in terms of OpEx and CapEx combined, as well as the Uber Health investment, we're looking at a $46 million investment. However, the total savings and the margin we will get from implementing Navi is nearly $257 million, which is a significant benefit to cost ratio. So in terms of thinking where we get these significant savings and margins, they really fall into 5 verticals here. And all of these verticals here are very significant to our financial improvement, but also fall into line with UCLA's sustainability, resilience, and growth. So we're looking at access and navigation optimization, increasing administrative and operational efficiency, improving IT and EHR integration, increasing patient retention as well as revenue growth, and then improved governance, security, and equity as we navigate our digital age. So to tie this back with our dear friend Maria here, this slide really captures the transformative effects that Navi has on Maria. So now with Navi, Maria is able to get timely, appropriate care from the right places at the right time. She's also has lower out-of-pocket costs, and she also has stronger education about her own health literacy, both in terms of her own healthcare needs, as well as where to go to access those. We've already spoken a little bit about UCLA Health's benefits. So we really see this as a system level win-win for both the patients and the health system. So to sort of recap everything we've talked about today, we understand that this is a bold and transformative solution that we're recommending, but we do recommend it to UCLA Health because we believe UCLA Health is very well positioned to undertake such a strategy. We know that UCLA Health is one of the most recognized health systems in the country and has the resources necessary to champion this change. We also understand that LA's very diverse patient population lends an excellent opportunity to improve patient access and equity, both of which are central to UCLA Health's guiding principles. And lastly, we want to emphasize that this strategy is not just about adding technology for the sake of adding technology, but it's about leveraging innovation tools in this very digital age to transform the lives and the communities of people like Maria, as well as to improve and to scale UCLA's legacy of excellence. So with that being said, thank you for your time, and we'll now open it to any questions.
All right, fantastic job. Really great idea. So great job, team. Question about the workflow and the patient journey a little bit. So patient calls up the call center, they do the triage. I get that. It schedules an appointment. We can send the Uber. We can save an ED visit. All that great stuff. That's actually what we're working on right now. So it's very timely. Have you guys thought about if the patient actually shows up at the ER? Is this built into that at all? Because that's how most of the patients actually get to the ER, right? They don't call us first. So have you thought about that?
That was our strategy with Navi. We hope to prevent that walk-in, but if we do have a walk-in, we will, in the staff training, be able to educate those patients on Navi to use it for the next time. I think that is going to have to be something that just happens, but we're with the aim trying to decrease ED walk-ins.
Thanks, guys. So Navi has a lot of technical components behind here, or the agent, and so I'm curious. Are you proposing that we build all of these technical aspects, like we come up with the voice agent, or we choose like an open source LLM and maybe like tune it for our uses, or are you considering where we seek out partners to fill in the gaps along the way?
Yes, more to the latter half of that. So we're anticipating a hybrid approach where we have vendors who can help us with sort of the core API features, but there'll be a lot of custom built models on top of that that are central and customizable to UCLA Health specifically.
And then similar to Jeff's question, so a lot of people also enter work or the care workflow not through a voice call, but maybe through the patient portal. So by messaging, would Navi also have a chat function theoretically?
Absolutely. So Navi is intended to be multimodal. So it can have the call feature, it can have SMS, it can have kiosks. So it will be multimodal and accessible through a variety of different entry points.
Yeah, and with that integration through Epic, the patient portal as well. Yeah.
Yes.
Excellent job. I'm going to dive in deeper to the multi-language capacity of Navi. When you think about its accuracy, how does Navi validate the medical accuracy of its multi-language capacity?
Yes, so a key thing to point out is that Navi is not intended to be diagnostic in any sort of capacity. So in terms of offering clinical advice, that would not be built into its capabilities. It's more to triage the patient's appropriate site of care based on the symptoms it receives. Of course, the accuracy is going to be built into the language when it's being modeled and when it's being structured, but that is something that we will continuously monitor with a lot of strong clinician oversight as it's being developed.
I can also add on, throughout the pilot process, we want to work with this with actual patients. So we're finding out what languages they're speaking and how we can make this more accurate for them. So we'll see, like, is this helping you? How accurate is this? And do you feel that this is working for you?
Yeah, and that definitely goes into our KPIs. We definitely want to make sure that we're involving providers and patients to see if it's actually providing the benefit that we want it to.
Thank you.
Thank you, guys. Great job. In reviewing the 8 capabilities of Navi, was there one that stood out to you that you thought would be the most important for us to maybe move forward with first?
In terms of its triaging capabilities or to?
Just in general, considering the
I see.
problem statement
Yes.
that we have of the 8 capabilities?
Yeah, I can take that. I think I would say that the most important would probably be in terms of would be the predictive scheduling and no-shows in terms to get people to primary care providers. We know that things like transportation barriers can keep people from getting to their primary care appointments. And that's a large problem in healthcare today. So that was one of the most important that we felt.
Yeah, and just to build on that, with the capacity strain, we definitely had Navi in mind to kind of redirect patients, improve the operational efficiency of the entire health system. So I think number 3 also, with the predictive scheduling, it'll be able to see the capacity, all the UCLA health sites and direct them accordingly.
And I
Thank
would
you.
also add that 1 is listed as one of the capabilities, but I would say 1 is almost like a more overarching feature and the other 7 sort of support number 1.
Thank you.
Hi, great job, guys. If I remember correctly, I think this is a $50 million or so investment with a 250 ROI. When I look at the 8 categories on the screen, can you maybe just tell me what are the top 3 capabilities that are driving that ROI? So, for example, when I see number 6 for care gap identification, where we're improving measure compliance and so on, we have programs where we're paid additional incentives for high performance. So that's one type of revenue capture. Or for number 7, reducing out-of-network leakage. Financial impact of that is that we're able to retain patients in our system and keep the monies from the payers within our system instead of it leaking out to another system. In your mind, for these top 8, what were those top 3 that are driving that 250 million ROI?
That's a great question. And I think I would begin by saying all of these are very interrelated and very synergistically related. So if you're thinking about, let's say, reducing hospital readmissions, you're going to have a financial ROI because readmissions do affect polymetrics, which affect revenue. And we're also going to ensure the patient is more educated on where to go for care. So in the future, they're less likely to use the ED, which is a very high cost site of care.
Yeah, I just went to the side that shows the revenue capture for the average cost of an unnecessary ED visit is $2,000. So that's where that large is coming from. And then, sorry, I didn't mean to cut you off, but just from operational efficiency through Navi and rerouting everyone everywhere. I know those 8 were kind of separated, but they're all kind of synergistic together.
Thank you.
Judges, this presentation is behind tab 3. Just a reminder, you want to hold the microphone close to your mouth. So the judges will introduce themselves and then the team can go ahead.
Okay, great. Welcome, you guys. Thank you for coming here. My name is Julia. I'm our Chief Patient Experience Officer.
Hi, Paul Lukac. I'm a pediatrician and I'm the Chief Artificial Intelligence Officer.
Hi, everyone. Jeff Butler. I'm COO for our Community Clinic Network.
Good afternoon, everyone. I am Deisha Brown, Senior Director of Community Clinics Operations.
Hi, everyone. I'm Albert Tentugan. I'm the Chief Data Analytics Officer.
Well, thank you for having us. We're C Consulting. I'm Anthony. This is Emma, Estefania, and Saisindu. We can confidently say that everyone in this room has felt the pressures or heard of LA traffic. You leave 5 minutes late, hit one red light, and suddenly you're stuck. No control, no visibility, no idea how long it's going to take. Now imagine that same feeling, but instead of being late to work, you're trying to book a doctor's appointment, or you're in an ED wait room, or you've been discharged, but no one has come by with any answers. You're stuck in the system. That experience reflects a greater issue across all US healthcare, one that even leading systems like UCLA Health are trying to navigate today. How do we clear the congestion from care to entry to exit that works at scale?
As you all know, UCLA Health is a national leader in clinical excellence and innovation. This system cares for almost 900,000 people every year and has one of the most diverse and complex patient populations in the country. Today, UCLA Health manages over 5 million calls annually and has routine occupancy of over 100% across several of its systems. This puts pressure on the patient journey from scheduling to the patient experience in the ED to patient discharge. But it isn't a failure of clinical quality, it's a flow breakdown, and patients are the ones who feel it first. We sought to find the most effective and valuable uses of AI in mitigating this congestion. With the goals of remaining patient-centered, integrated, and intentional, we first provide an on-ramp to care with our AI-enabled call center. Next, your route to care, an AI kiosk triage. And finally, a clear navigation of care with SmartChart. These initiatives will expand access for patients, reduce wait times, and ensure a smoother caregiving journey for all.
As mentioned, UCLA Health handles a high volumes of calls coming in. To alleviate with over a 4% call abandonment rate. To alleviate this issue, we propose the On-Ramp to Care initiative, an AI-enabled call center using Elise AI. Elise AI is a conversational scheduling tool that works alongside FTEs and does not replace them. It uses natural human-like language that completes full scheduling workflows, supports multiple languages, and integrates safely with Epic in a HIPAA-compliant way. For this assessment, we looked into the real estate industry, an industry that also manages high volumes of calls coming in. Using AI agents like Elise AI, renters saw an average response time of less than 60 seconds and a reduction in staff workload.
Taken together, these capabilities position Elise AI not as a standalone tool, but as a scalable infrastructure for access management. As the only HIPAA-compliant voice AI agent on the market, it enables UCLA Health to modernize front door operations in a way that is incremental, measurable, and aligned with long-term system goals. We start on-ramp to care with a 6-month pilot in primary care, where call volume is high and most requests are low complexity, making it the safest place to deploy Elise AI. We start by integrating the platform and gradually scale as we track for access, quality, and patient experience. At the end of 6 months, we make a data-driven, go-forward decision and scale by routing more calls to Elise AI, expanding across UCLA Health over 3 years, driving sustained access gains while optimizing talent without adding labor. Because of this pilot, we see break-even and gains in year 1. By year 3, we see over $15 million in annual net operating benefit as access recovery and call abandonment improvements ramp. At its core, this is an access investment, unlocking faster scheduling, recover lost demand, and higher value staff utilization.
We introduced On-Ramp to Care to help patients get their questions answered before they start their care journey. Now imagine you're a patient that directly comes to a UCLA ED, and now you need to find a way to navigate this traffic congestion at this critical point of entry. Dual Route to Care initiative is our solution for this problem. Located within all UCLA Health EDs, it involves an AI kiosk triage process that allows you to choose your route to save faster care while also improving ED flow. The AI kiosk triage process captures symptoms and key details at arrival. Utilizing real-time triage intelligence, it stratifies patients by acuity level and recommends the most appropriate care pathway after clinician confirmation. This reduces ED bottlenecks and helps ensure that high-risk patients are prioritized sooner. Dual Route to Care initiative looks like this. Say you arrive at the UCLA Santa Monica ED, you can either check in as usual or go to the AI kiosk triage. If you go to the kiosk, you complete a thorough symptom adaptive questionnaire that's then reviewed by a clinician to confirm your acuity. For patients with lower acuity needs, real wait times are displayed on your phone or iPad, allowing you to choose whether to remain in the ED or seek care at a different site. In the background, all this information flows seamlessly into Epic, supporting clinician oversight and improving ED flow. For this initiative, we were inspired by the aviation industry. Over 60% of travelers prefer using kiosks, and this has dramatically reduced wait times. This demonstrates that giving travelers the option of a self-service kiosk improves flow without adding staff or physical capacity. From the patient perspective, this is all about access and choice. The kiosk gives patients the option to avoid this congestion and reach their care site at an appropriate and fast manner, while always preserving the option to stay at the ED and receive care there if they want. Operationally, this is both a throughput and financial return investment. Higher acuity, high value patients can still be seen in the ED, while lower acuity patients remain within the UCLA Health System through urgent care. This increases bed turnover in the EDs and increases efficiency and capacity.
UCLA urgent cares are already utilizing predictive wait time technology. With multiple urgent cares being located near the Santa Monica ED, Santa Monica proves itself as a strong and practical pilot location for this. In the beginning, we're laying the foundation by integrating Epic with the kiosk, developing the model, and training necessary staff. So for the first 2 years, we'll be developing and in development stages. On year 3, we pilot the Your Route to Care initiative in the Santa Monica ED. And then on year 4 and 5, we'll scale this initiative across the organization in all UCLA Health EDs using the insights that we gained in the pilot. We're laying the foundation in year 1 and 2 by building the infrastructure, redesigning workflows, and validating the model. So we do see a temporary negative net benefit at first. But by year 3, we're essentially at break even as diversion and throughput improvements start to show up. In year 4, the program turns cash flow positive, generating about $4.8 million in annual net operating benefit a year, and then evening out to about $4.6 million after that.
We've shown how Your Route to Care helps patients avoid congestion and reach the right care setting. But once they're in the system, there's another kind of traffic we have to clear: the chart itself. Navigating a patient chart can feel like being stuck in traffic with no visibility as to what's actually causing the slowdown. Clear navigation of care is our response to that challenge, and SmartChart is a tool that makes it possible. UCLA Health already has a strong AI foundation in place through its multimodal embedding model for EHR, or MEME, which turns complex EHR data into clinician-style narrative summaries. This not only allows large language models to interpret patient information, but it also mitigates for black box concerns. The building blocks for clear navigation of care are already here. So if MEME is the engine behind clear navigation of care, SmartChart is what puts that intelligence into clinicians' hands. It brings together MEME summaries, operational data, and predictive risk signals into one conversational view. Instead of hunting through the chart, clinicians can ask natural language questions and receive real-time, decision-ready answers. And this isn't about replacing clinical judgment, it's about augmenting it. This is how clear navigation of care works in practice. A clinician can ask a simple question like, what's the delay in room 147's discharge? SmartChart returns a clear, real-time answer, separating clinical readiness from care coordination factors. This supports faster decisions, smoother discharge flow, and an overall clear navigation throughout the entire care process. SmartChart drives impact across multiple key areas. Operationally, it reduces length of stay and directly impacts system capacity. For providers, it allows them to practice at the top of their license by minimizing cognitive load and chart searching. And for patients, it provides a smoother journey for all, reducing delays and decision-making time. These improvements position SmartChart not only as a system performer, but also as a safety driver.
This idea is grounded in what we've seen already work for other high throughput industries. In retail, AI conversational tools have decreased and reduced resolution time by over 50% and have shifted staff efforts towards higher value care. Similar to the AI kiosk triage, the implementation timeline for SmartChart is also 5 years so that it can be safely scaled throughout all of UCLA Health. The first 2 years are all about creating SmartChart. So that involves AI development, EHR and Epic integration, and thorough staff training. Year 3 pilots SmartChart right here in Ronald Reagan in the West 6 of the MedSurg unit. Years 4 and 5 is scaling SmartChart throughout all of UCLA Health using lessons we learned from the pilot. As we mentioned, initially the first few years of SmartChart development is really creating SmartChart. So initially we see limited savings, but by year 3, this dramatically ramps up and we see about $6.3 million in savings and about negative $1.3 million in net negative impact. But once SmartChart is fully scaled throughout all of UCLA Health, we see about $17.1 million in annual net operating benefit. And once it's fully operational, we'll see recurring gains through reductions in avoidable utilizations and efficiency gains.
Now that we've shown the strategies and their impact, we shift to how we fuel these initiatives responsibly. After 5 years, these 3 initiatives produce over $37 million in annual net operating benefit, each targeting a different lever, including access recovery, ED capacity management, and length of stay reduction, creating both near-term and system-level value.
In designing this approach, we were deliberate about every detail, focusing on cybersecurity, environmental impact, change management, and overall experience. These strategies fit seamlessly into UCLA Health's existing operational workflows and security framework. Taken together, these initiatives are not only innovative, but responsible and ready to scale.
To measure success, we aligned our KPIs directly with the patient journey. For our on-ramp to care, we're focusing on call abandonment rates. Your route to care is about ED lobby wait times, and clear navigation is time to clinical decision support. We started with traffic, the feeling of being stuck, with no clear path forward. Using our initiatives of on-ramp to care, your route to care, and clear navigation to care is how UCLA Health gets unstuck. Not by adding more lanes, but by making the system smarter. Thank you for your time. We're open to questions.
All right, I'll start. Great job, really good ideas. I like the traffic, metaphorically clearing the lanes, that was good. a lot of changes in call center and ER that will affect a lot of different people. You kind of briefly mentioned at the end change management. Talk a little bit more about how you would roll this out across the system, knowing it's going to touch thousands and thousands of people and change their daily work.
Thank you so much for your question. So we know that Dr. Lukac here is the co-chair of the AI Council, so that team would be leading these projects. Additionally, we have accounted for the vendor, Elise AI, for the call center and what they would be held responsible for. Most of it is under Elise AI, as they have implemented this technology across other healthcare systems in the United States and already work by integrating into Epic. So other than that, we have the teams here at UCLA that are necessary to roll these out, and we have outlined what teams would be necessary. So for example, compliance and legal would be in charge of that contracting and that governance alignment that UCLA Health has stressed in their AI goals. Overall, this does touch a lot of people. So we want to ensure that we're not only looping in the AI Council and the vendor, but taking alongside leadership and our frontline workers throughout the development phases of these initiatives.
Thank you all. That's this is really great. I'm thinking about the kiosk in the ED and thinking about the demographic of patients that come into the ED, many of whom are traumas, many of whom are incapacitated, many of whom are not, don't have the ability to fill out a kiosk at any point. And oftentimes they're coming in solo. How do we think about patients that can't fill out the kiosk? And is there an expectation that it's only a certain percentage of folks that can fill out the kiosk? Is that the percentage that's going to help reduce your traffic, or is there a hope and expectation that it's 100%?
Excellent question. We realize that a lot of the people coming into the ED are going to be incapacitated or going to be in a vulnerable state. The kiosk is always going to be optional. Patients never have to go to the kiosk. The receptionist and the front desk staff will always be there to welcome and support those patients in need. That said, we know from the aviation industry that 60% of patients or 60% of travelers prefer the kiosk. So this kiosk is really intended for those lower acuity patients who can get care in other state or other contexts or other locations that might be more appropriate for them. So we fully expect that not 100% of ED patients will be utilizing these kiosks, and that is factored into our strategy.
I have a question. So for Smart Chart, in theory, that is something that we all expect that Epic will eventually do, in theory. And so I'm wondering, are you making an argument for us to build that internally? And what is that argument for doing so?
Yeah, great question. Thank you so much. So as we know, Stanford actually has already done like this homegrown version of Smart Chart through its chat EHR. And Epic is in the piloting phases of something similar like this at their other locations, across the United States with other systems. What makes Smart Chart unique is UCLA's existing AI capabilities. UCLA is unique in the fact that it has the multimodal embedding model for EHR, MEME. MEME allows for large language models to interpret patient information rather than trying to make the EHR and that fragmented data be readable to large language models that cannot do that. Additionally, with what is existing at UCLA Health, that mitigates for black box concerns that haven't fully been accounted for by Epic. And this allows UCLA to be an example and at the forefront of innovation while still having that unique touch that gives you an edge.
Thank you.
Thank you, everyone. Great job. Similar to Julia, I'm thinking about the patient kiosk again, and I wanted to know if you have any information around how long it will take a patient to navigate through the kiosk, and if you have any data around adoption from a patient experience perspective on satisfaction rates?
Thank you so much for your question. That was a great question. So for the AI kiosk triage, this is a pretty quick process, and this is a simulation that will kind of show you how it would potentially work. So for patients, once they check in and they put in their key details, so their insurance card, driver's license, to really capture those details really fast, especially in those kind of patient cases where they might not be able to correctly input everything. This will quickly get through that process. And then with the symptom questionnaire, even though that's thorough, that'll quickly get done. And then that will generate an acuity level that will get checked by the clinician first. And then that will either go to the patient's phone because they put in the phone number if they have one, or they can grab a iPad that will be in the ED and they can get all this information there. So once the clinician approves this, they'll get the acuity level that will kind of match up with these urgent care locations to kind of predict these wait times. And UCLA already has urgent care times kind of built into their system. So this really integrates it into the kiosk and brings this into the EHR and really integrates it into the EHR so that if they do end up going to the ED, then all that triaging is already done. This saves a lot of time for the patients on their end and travel in terms of waiting, and also saves a lot of time for the clinicians that are taking these initial notes. And to kind of add on to that, kiosks have been used throughout all over the nations for different purposes. I specifically want to point out Cleveland Clinic. They have kiosks and their centralized patient check-in for all of their locations, and they have been received very well. So for lower acuity patients coming in, we know that this will be received very well if they're able to put in all that information, and people will always be there to help you, and you can always go to the front desk if you need additional help.
Hey guys, nice presentation. I like the transportation metaphor, and Anthony, your term congestion of care is great. I haven't heard that one before. Having had a cold during the holidays, I can empathize with that. Can you show me the rollout plan again? I think it was a 5-year plan.
Is there a specific, is it AI kiosk or smart chart that you're thinking?
Let's go with the kiosk. Yeah, there we go.
Oh, there it is.
Yeah. So just developing the model and training it, I see it takes 2 years. We have a pilot in year 3. Do you see an opportunity to create a minimum viable product with a shorter time frame where maybe we can iterate over time? So we'd get an MVP out in year 1, improve on that for year 2 and beyond. If so, what would that MVP product look like, where maybe you'd shave off some of the features and get something that can be deployed quickly?
That was a great question. Thank you. So this is our really suggested timeline, kind of looking at other industries and also looking at other AI tools that have been similar to this. So with this, because we are developing this internally, we suggest about 2 years for training and creation of it, but this can be adjusted based on what kind of features UCLA wants. We specifically have the pilot being about a year at Santa Monica, especially it being near all these urgent care sites for you to get the full impact. But this pilot can definitely demonstrate changes that need to be made. So all the internal teams, the AI council, all the frontline staff, they will actively be engaged in all the changes and be able to put in some of the inputs and suggest some features so that this can really be catered to UCLA and maybe even potentially be rolled out to other settings within UCLA where these kind of kiosks and triage systems would really create a system-wide impact.
Thank you.
Judges, the next team is behind tab 1. Okay. Bryant, I did something wrong. No, I didn't. Sorry, guys.
Okay.
I was organized before. Thanks.
Thank you.
You want to speak close to the.
Okay, got it.
The judges are going to introduce themselves and then you can start.
Hello, team. Guys ready? All right. I'm Jeff Butler, COO for our community clinic network here at UCLA Health.
Hi, Paul Lukac. I'm a pediatrician and I'm the Chief Artificial Intelligence Officer at UCLA Health.
Hi all, I'm Julia Gaviria. I'm our Chief Patient Experience Officer.
Good afternoon. I'm Deisha Brown, Senior Director of Community Clinics Operations.
Hi, I'm Albert Tentugan. I'm the Chief Data Analytics Officer.
Picture this. You're sick or your kid is injured and you call UCLA Health only to be placed on hold. You tried the website too, but you're not sure where to begin. Now, imagine you call and you're booked within seconds. No waiting, no guessing, just clarity. That contrast isn't about people, it's about access design. And that's our focus for today. We're a dream team. Ruchi, Mia, David, and I'm Elizabeth. And our dream for UCLA Health is smart, bold, and realistic. Our proposal focuses on two independent but complementary patient-facing operational workflows: an AI-enhanced call center and AI scheduling and appointment management. These are the front doors to the health system. They determine how patients experience care, how staff experience their work, and how well UCLA Health can deliver on its mission. Strengthening these two makes access intuitive for patients, sustainable for staff, and faithful to UCLA's high-touch model of healing humankind one patient at a time. We anchor our strategy around two goals. The first, human-led AI-assisted operations. The second, improved patient experience and access. That translates into using AI to focus on core operational workflows, specifically in high-impact, high-burden areas. Together, these goals support our vision, which is to position UCLA Health as the West Coast leader in AI-driven healthcare operations. To ground our strategy, we looked outside of healthcare at three industries already using AI. The first, legal, which teaches us to use AI for document and transcription workflows. The second, cybersecurity, which teaches us to use AI to detect operational threats. And the third, e-commerce, which teaches us to use AI to forecast and redistribute resources. The commonality is that AI is detecting, predicting, and accelerating operations, and that is the exact same model we apply to patient access, scheduling, and capacity at UCLA Health.
This slide summarizes our proposal one. On the left are three access channels communicating with each other: website assistant, text message, and call center. Each designed to handle routine requests with escalation as needed. On the left are the outcome goals we are targeting with this proposal one. We are looking at abandonment rate reduced by less than 2%, improved patient self-service containment. We are trying to reduce average handle time and overall improve patient satisfaction score, allowing us to match demands without matching staffing needs. On the right bottom is our integration backbone. We are trying to integrate Epic EHR connected with customer relationship management and contact center as service platform in a HIPAA compliant environment. The key takeaway with this proposal is to
add a single integrated access layer to improve performance and scalability without adding complexity. The first place to see this in action is at the front door, at the website. Let's begin with an example here. This is our patient going to our website, and he types, "Find a cardiologist near Westwood." Now this prompt stays on the website. The AI assistant filters the providers in the area, prompts to log in, schedules an appointment, and routes the request to the right queue, handing off securely to My UCLA Health. This platform can be used to address simple access questions associated with insurance, billing, provider scheduling, and frequently asked questions available 24/7 and in multiple languages. With this model, we aim to hit for 1.2 million in annual labor savings and 20 to 35% deflection rate, where website-originated inquiries are resolved without escalation. Simple questions remain simple and don't turn into calls is our goal. However, for interactions that require live assistance, our experience expands into our call center. Let's again begin with an example here. A patient calls UCLA and says, "I'm calling about a billing issue." Now our AI IVR will identify the intent, handle authentication, and route the request to the right queue. We also have an ability to use this AI IVR in helping our agents with the real-time information, knowledge surfacing, compliance prompts, and writing the auto summaries back into the Epic for future reference. Another model that we can look at with this proposal is for higher acuity patients. The call ahead conversations can be recorded, and the ED and the nurse can be notified regarding the ETA and chief complaint to better prepare the room to receive the patient, to rule out staffing needs, and to reduce bottlenecks. With this proposal, we are aiming for less than 2% abandonment rate, 3.5 million in annual labor saving, 25 to 35% reduced average handle time, and overall improving quality and compliance. For the fastest resolution, sometimes we don't require a call. And in that case, the friction drops the fastest at the level of text messaging. Now, with text messaging, we are looking at two-way SMS, which means a patient can reply to a reminder regarding an appointment. And let's say a patient types back saying, "I need help rescheduling." In this case, the AI identifies the intent, looks for the slot, books the slots, sends a confirmation, updates it into Epic. All of this done without any staff involvement. With this model, we can utilize this to send reminders, schedule appointments, send educational content to the patient before the appointment, send marketing and surveys. With this model, our goal is at the bottom, you can see the ROI profile. We are looking at more than 1 million in annual labor saving and 400% return on investment by year 2. In the center bottom, you can look at the impact we are targeting. We are looking to reduce no-show response, reduce response time, call volume deflection by sending reminders and scheduling. And on the left bottom is the KPIs we are targeting, which is we'll keep a track of no-show rate, SMS engagement, reschedule turnaround, and containment rate. The goal here is a proactive approach to make access scalable, measurable, and sustainable.
We conducted an analysis of leading AI contact center vendors, evaluating them across our channel coverages, which includes the website virtual assistant, AI call center, and text messaging, and also evaluating them in terms of Epic integration and healthcare depth. Here are the top list of vendors. Each of them have their own strength, which we listed on the right-hand column, but our recommended vendor is at the top of our list, highlighted with the green icon, Core AI. The reason why we're choosing Core AI is because it has an omni-channel platform that connects all these proposed channels together and creates a seamless experience, and it also has epic interoperability. Core AI is also used at large healthcare organizations today, like Kaiser Permanente and Pfizer, demonstrating both scalability and healthcare grade maturity. If we look at our roadmaps, they're designed to scale early and or bring value early and build responsibly. Proposal 1's roadmap first starts off with our pilot. We begin with the website virtual assistants and contact center agents with interactive voice response, IVR. The primary focus of this phase is to confirm operational fit and also confirm adoption and performance. Phase 2 is where we scale, we add text automation, and also expand across all primary care lines. And lastly, phase 4 is where we optimize and modify these omni-channel experiences based off of staff and patient feedback.
Our second proposal here is an automated scheduling and appointment management system that integrates artificial intelligence into UCLA Health scheduling system. For a quick overview on this technology, machine learning predictive systems are able to integrate and analyze historic patient data, including demographic data, histories of past absences, and other variables to produce a unique risk score for each patient. High-risk patients are then able to be identified and proactively engaged to either confirm their arrival for the day or to schedule their appointment as needed. Our outcome goals for our second proposal on the right: first, and very importantly, we want to reduce the no-show rate by 20%. Second, we want to improve appointment utilization rate by 3 to 8%. And lastly, we want to reduce manual labor by 5 to 10%. This software will integrate into UCLA Health's EHR, registration, and referral systems. So why is Dream Team so interested in patient no-shows? They are a chronic issue across all health systems that are costing the U.S. Health industry about $150 billion annually. We can actually illustrate the cost of this issue using Ronald Reagan Medical Center as an example. First, the LA County Department of Health Services recently estimated the no-show rate to be around 20%. Industry research sets the cost for each patient no-show at around $200. With the annual patient volume here at Ronald Reagan at around 607,000 patients per year, we can actually estimate the total cost here at Ronald Reagan Medical Center. So we estimate that UCLA Ronald Reagan Medical Center is losing about $24,280,000 per year solely due to patient no-shows. Dream Team is really excited about the power of predictive models. Current systems are very powerful and only getting more sophisticated. We envision in the next year for predictive models to be integrated across all departments, across all health systems. Select models that we're looking at are able to predict all appointments about 93% of the time and all patient no-shows about 80% of the time. If we account for this information and proactively use it, research shows that we can save about 20%. We can actually reduce the no-show rate by about 20%. So if we go back to our figure at the bottom and account for those savings, UCLA Ronald Reagan Medical Center is poised to save about $4,856,000 annually if we implement such systems.
Our roadmap for proposal 2 is broken out into 4 phases, each spanning a year. The first phase is the pilot. So this is where we align all key groups and deploy in a select department, of course, with oversight to confirm operational fit. In the next phase is where we scale. We expand the range of patient data and introduce no-show prediction. The primary focus of this phase is on change management and training. Phase 3 is where we optimize and expand enterprise-wide and also integrate with existing systems, which leads us to phase 4, continuous process improvement, and long-term value realization, where KPI performance leads to targeted investments. Now, here's a summarization of everything that we discussed. Proposal 1, Proposal 2 is our breakdown, and the reason why we're discussing these proposals together is to show the value that each of these channels bring on their own. They can work independently, but are intended to work together and are stronger together. This is meaningful because it shows where automation delivers the greatest improvements in a personalized patient care.
We created an implementation plan that ensures AI is adopted and not imposed. On the left in blue, we have our foundation, like governance, understanding our current state, and define problems. We also move on to an execution and sustainability phase where we're really looking at it from a bird's eye view of implementation, integration, and expanding. We considered AI use for revenue cycle management. However, given our focus of access for this proposal, we rejected it and we recommend it as a future phase initiative. Our guiding principle is simple. AI is the tool, people are the purpose. A human-led AI-assisted approach allows us to reduce friction and automate routine work while people remain accountable. This is how UCLA Health leads the next era of operational excellence. Thank you. We're happy to take your questions.
All right, great work. A lot of really good ideas in there. So thanks for sharing. I liked how you guys started with real world problems that we're actually trying to solve today. So that was very, very relevant. As we think about the next 5 years after this, what are some other ideas that you guys talked about in the next 5 years? Because AI is going to bring a lot of new things. And so I think the call center and the scheduling is good, but what else besides that?
Yeah, I could speak a little bit on that. I think one of our first interests when looking at these two proposals was looking at the AI foundation that UCLA Health was already placing. We think that both of these proposals kind of plug in after we're able to build that strong foundation. For example, we were specifically focused on patient experience for both of these proposals, but UCLA Health is already pushing a lot in clinical AI. So we pretty much envision widespread throughout the whole health system, revenue cycle, patient experience, clinical will be a big area in the future.
Okay, I'll chime in. Great presentation, guys. Some comments or some thoughts that come to mind. You called out how UCLA would be on its way to being the West Coast leader. I think within our leadership team, we like to think of ourselves as a national leader or a world leader. So, so you can aim higher. It's okay. Don't be shy. Another thing that just stuck out to me was it's interesting that you called out that the revenue cycle is an area not to focus on right now. If you read the literature, you would think that that's the first area to jump at. But just with my colleagues here, we're finding that there's far more excitement outside the rev cycle, which is interesting. And a lot of our efforts are drawn to that. So you predicted that well. You must have used a cool machine learning model for that. This one's a little question for you. You called out the term predictive ML on your slides. In your mind, are you including generative AI with that or versus classic predictive machine learning? It's kind of a semantic thing, but just wanted to see where your head was at there.
Yeah, I could speak on that. I think we're thinking of classic machine learning. We're really interested in getting into an ideal state where we're able to integrate all patient data across the health system, find trends on information that's already available, and kind of focus on what other variables we could pick up on. So that's where we're headed.
I do want to add, the machine learning is also focused on being more humanistic. So we want these interactions to be thoughtful of the patient and not just on like workflow. It's truly, as we said, the front doors of patient care.
Okay. And next question was, Interesting on your slide, you called out a loss in FTEs, like that was a savings opportunity. I saw number 10 and 35 and stuff. Do you see any opportunities to retrain that workforce to do something else in the system as opposed to letting that headcount drop?
Yeah, I can speak a little bit on that. That is a huge consideration across the healthcare industry. We're thinking about such a disruptive technology that's going to create a new paradigm shift, but we believe that the strategy of UCLA Health and any health system is to retain and reskill as many employees as possible. So we're thinking about these proposals. We're thinking about change management, how that's going to look like, and giving employees opportunity for longevity here in the health system.
Okay, cool.
I would also like to add to that. We believe UCLA is growing and it will continue to grow. And we have a lot of opportunity to utilize the same manforce to reach the goals that we desire to. So.
Thank you.
I'll ask one last question. I wanted to go to the proposal back to the predictive model for no-shows. So that's somewhat long established. Even Epic had a model a few years ago about no-show prediction. And so I'm wondering, what is we can probably build something that's excellent for flagging likelihood of showing up for your clinic visit, but the harder part is making sure they're like rescheduled or seeing what their needs are to get into their visit, what have you. So I think what I'm looking at the slides, you were a little light on that. So can you explain that part of things? Like how are you going to, help those patients reschedule or help them get to their visit on time? And maybe you don't even have to reschedule.
Yeah, definitely. It's another big consideration. We're envisioning this software to bolster the current human workforce. So to walk you through, when this risk score is generated, it could be used in different channels, either used automatically for double scheduling, for example, or putting patients on the wait list. But we are really interested in how these technologies can reduce manual labor. So the specific workflow that we're envisioning is using these risk scores to help schedulers, human schedulers, outline which patients are high risk and likely not to show. And then we're thinking phone calls from your providers, specific outreach, whether they need transportation, but really kind of giving people a chance to zero in.
And I do want to provide more insight. That was some of the considerations in our research. Of course, text messaging, website, and call center is how we're going to push and reach out to these patients, but it's also highly customizable, and that's the importance. Our research focused on patients who had different language complications that were more likely to show up when we understood their background, understood their language, and had like a more understanding of their healthcare system as a whole. So we would definitely want to integrate a piece of that and some of the research that we found.
Okay, I want to thank you all for joining us this afternoon. I hope you enjoyed those presentations. I hope you got a few tidbits for yourselves. The next phase actually the final phase of our case competition is our closing reception, which is going to be upstairs in the courtyard. It's called the Garden of Peace. And so we can all head up there. There are drinks and snacks, and that's where we'll announce the final order of the winning teams. So we'll see you upstairs.
Oh yeah, I can't. I have to be so I wasn't going to join. Okay. It wasn't.
That's okay. That's okay. Okay, I'm sorry. I'm sorry. No, that's okay. But before you go, yes, let's decide. Yes, well, you just set that up there on the call.
Doing flashbacks.
Yeah.
Yeah.